Good evening, aspirants and our honorable faculty. Today's class is about nutrition, which will be conducted by Dr. Abdul Samad Ansari, sir. He is a director in critical care services at NANAVATI Max Super Speciality Hospital in Mumbai. His area of interest are as follows: mechanical ventilation, sepsis management, extracorporeal supports, and infectious diseases. Over to you, sir.
Thank you, everyone. First of all, it gives me immense pleasure to, kind of welcome all of you for this academic feast and the EDIC preparatory program. And Farz Academy has been doing a wonderful work, we all know, for the last decade. Very happy to be a part of this team. The domain area which I have been, requested to kind of take care would be nutrition. So I would be very happy at any point of time. If you want to ask, interrupt, I'll be more than happy. Just kind of without any introduction, just say, excuse me, sir, and please interject if you want and ask for any explanation. For the next 1 hour, I would like to, kind of go ahead with an overview on nutrition and would also try to talk about what are the basic guidelines that we should be aware of. And lastly, certain questions which I feel would be mostly centered around nutrition in your EDIC exam, part 1. So I am at NANAVATI Super Speciality Hospital, which is in Mumbai, and I look after critical care services, and I'm the director there. As you can look, the food pyramid looks very interesting, and it's not exactly up to the scale, but you can see the carbs are usually shown as the most important base. And on top of it comes the proteins in various forms, animal, veg proteins, and then comes a lot of interspersed areas of vital minerals and vitamins and other trace elements finally come up. And then obviously fats and lipids come along. So on top of it, if you look at that, there is a small bottle of olive oil. And at the base, you can see all forms of, breads and including millets, the power food that we are actually celebrating these days. When we talk about complete nutrition, you all know that it's actually a mixture of carbs and protein. Carbohydrates and fats can be called as the yin, and proteins can be like the yang. But still, the day and night, the yin and the yang, the positive and the negative, both have their very important role. And different levels of carbohydrate, fat, and protein intake can have a lot of effect on the protein metabolism and thermogenesis. If you look at that, the metabolism, especially protein metabolism, will get affected adversely if the protein content is less, while the thermogenesis will be good if you have carbohydrates and fats more in your diet, but so would be the fat deposition. But it's very important that when we talk about protein sparing action of carbohydrates and fats, that should never be forgotten when you are giving a nutritional prescription. That these carbs and fats are the most important way of salvaging proteolysis. So if you don't get enough carbohydrates and fat, the effect would be a direct breakdown of the proteins. At the same time, the non-protein calories are important, but the protein calories are as important. And the protein content for the nitrogen balance is highly important, as we see in the next slides. So complete and balanced nutrition is better than only protein supplements. We know that the protein sparing effect is about conservation of proteins for muscle tissue by using alternate sources of energy, and preferentially using carbohydrates and fat to provide energy so that proteins can be saved and reserved for the purpose of muscle building. An adequate amount of carbohydrates daily is very important for its protein sparing action. So one of the most important reasons why we have carbohydrates, apart from it tastes good and it gives you a bulk feeling of satisfaction, but it is most importantly the protein sparing action. When we talk about the SPEN guidelines, this is very important from the European perspective because you will be asked about that. The standard diet should cover the minimal energy needs, as we know, 25 kilocalories per kg actual body weight per day. And the minimum protein requirement is 0.8 to 1. But believe me, we are actually going towards an increasing protein content in the nutritional guidelines, going at least towards 1.2 gram per kgs. Now, that's something very, very important for the protein needs. And the proportion of carb, lipid, and protein is artificial but definitely a 50 to 60% should come from carbs, and lipids can have 25 to 35% of a ratio. And finally, the protein content, which is never counted usually for the energy intake, and at least 15 to 20% of energy can come from the protein sources. Malnutrition or risk of malnutrition, as we talk about, is one of the main indications for a high energy diet. And when we talk about a high energy diet, it is defined as a diet containing a calorie content of more than 30 kilocalories. So if you go back, if you remember, 25 kilocalories is something which is a standard. More than 30 becomes a high protein, high energy diet. And a high protein diet can start bordering towards 1 gram. But this is for a normal adult. When we are talking about a person who is going through thermogenesis, increased protein breakdown, increased stress, and any kind of mechanical ventilation or any kind of excessive stress on the body, especially pancreatitis, burns, this protein requirement will go up to 2 grams per kg, which we'll talk about. Now, when we talk about high protein diet, the other indications would be polymorbid medical patients, chronic liver disease, where a higher protein without having a non-branch chain. In fact, branch chain amino acids would be important inclusion. And for cancer patients where there is a significant catabolism, the protein intake can go up to 1.5 grams. In geriatric patients, again, you need to have a little higher protein for the ongoing breakdown. And for patients with decubitus ulcers, chronic pancreatitis, this intake will go up, and technically 1 to 1.5 gram per kg per day of the protein requirement would be required. So if they ask you the indications for high protein diet, chronic liver disease, cancer, decubitus ulcers, chronic pancreatitis, polymorbid medical patients. So these are some of the very important ways in which you can remember a question which can come from here. When we talk about, do we get what we want? Well, in kitchen feeds, if you look at the milk, 200 ml, calories 105, protein 6.4. And if you add these milk, buttermilk, soup, dal kanji, rice kanji, sago kanji, technically, they should be providing you as mentioned areas on the right. But again, they will all depend upon the sourcing from where they are coming from, the purity, and the way they have been produced and preserved during the transport. So milk are supposed to give you at least 3 grams from every 100 ml. And a good, sago or rice kanji will give you 50 to 70, kilocalories from 200 ml, and which is an average. If you have milk, buttermilk, soup, all of them, 1200 ml of this kind of kitchen feeds, you are only getting 373 kilocalories, which is a dismal number, though it sounds good. 1200 ml of variedly produced kitchen feeds, still not giving you 20 grams of protein and 500 kilocalories, which is really sad. And most of the hospitalized patients may not be able to take this amount of volume in a day easily. They may start, complaining of bloating and discomfort. So most important aspect is nutritional assessment and screening of malnutrition. And this is something which is important to be done in a structured manner. So SPEN recommends screening, which should be done within the first 24 to 48 hours and at regular intervals for any person who has long hospital stay, and definitely at the time of discharge. What are the various tools? You have lab tests, you have body mass index and composition analyzers, subjective global index, and then you have got those special tests like Nutrix scores, mini nutritional assessments, subjective global assessments, and Global Leadership Initiative on Malnutrition has also shown some GLIM and bioimpedance analysis, dual energy X-ray absorptiometry, magnetic resonance, muscle ultrasound, and lastly, a functional test like a hand grip. So please understand that they may ask you what are the various tools for assessment of nutrition, and they may have 1 or 2 of these on the board, and they may ask all of the above or none of the above. And what are the timings when the nutritional assessment should be done? When you talk about importance of nutrition screening, malnutrition assessment and screening, a comprehensive nutritional plan for the transition of care and a repeat nutrition. Sorry, somebody wants to say something? Okay, so these are the few advantages of regular screening and nutritional assessment during admission and discharge. It shortens the length of stay by 33%, improves weight restoration, and reduces long-term mortality by 37%. So if they ask you, malnutrition assessment and screening at discharge after a hospital stay is more important for a renewed functional recovery and reducing the financial burden, and has been very clearly shown to be beneficial even by Joint Commission Journal. In a nutshell, what is an effective nutrition care process? Malnutrition screening and nutritional assessment at admission. Looking at the cause by doing a diagnostic evaluation. For example, you may have a liver disease, you may have a burn, you may have pancreatitis or an ongoing sepsis. Then comes a nutrition care plan and therapy intervention. Then comes monitoring of what you are doing and evaluating the effects. And finally, malnutrition screening and discharge planning. So these 5 steps would be the most important way to know that there should be an effective nutritional care process. When we talk about a focus on oral nutrition supplements for malnutrition address, this was an important study which had shown that hospital malnutrition is a significant problem, but still remains under-recognized and under-treated in India. Has been shown that evaluation of change in nutritional status of patients in the surgical wards has been really bad, and status of nutrition support has been poor. Only 52% of the hospitals in India have a detection routine. And when you say detection routine, by doing a proper appropriate evaluation, assessment at regular intervals, and finally providing a targeted NSS, nutritional support service.